honored to be here with you all today. We have an incredible line of speakers. So I am not going to speak to you all right now because I'm going to pass the baton over to our amazing co-chair, Dr. Modele Ogunniyi, who will say a few words and then introduce Dr. Houry. So Modele, it's all yours.
Welcome, everybody. I am so excited that you all chose to join us today at the annual summit of the National Hypertension Control Roundtable. As you note, our theme today is Racing to the Top to Bring Down Blood Pressure. Credit to Dr. Janet Wright of the CDC for this theme, but I think that the theme reflects the urgency to control blood pressure. And as you note, we are focusing on hypertension control. And part of what we focus on at the roundtable is eliminating disparities in blood pressure control, because we know people are aware of blood pressure, people are being treated, though not being treated equally or not being treated enough, but where the greatest disparity lies is in controlling blood pressure. So we want you to sit down, if you are sitting down, but we want this to be interactive. We want to brainstorm today, and at the end of this summit, come up with tangible action items to push forward national hypertension control. It's a priority for all. And one thing I strongly believe is that until we eliminate disparities in hypertension control, we're not going to get to that goal. So I don't know if the chat is enabled, but I know that we have a lot of people online. If you can, type in the chat one word about how you're feeling about hypertension control. And at the end of the summit, we'll see whether you're more optimistic, you're more action-oriented, but we want to know, how are you feeling right now about hypertension, national hypertension control? And with that, I will introduce Dr. Debra Houry, a former colleague both at Emory and at Grady Hospital. She is the Chief Medical Officer and Deputy Director for Program and Science at the CDC. Most recently, she served as CDC's Acting Principal Deputy Director. And prior to that, she served as the Director of the National Center for Injury and Prevention Control. Like I previously mentioned, she was my colleague at Grady Hospital in the ER, where it's very familiar to me. She received her medical degree and an MPH from Tulane University, and she completed her residency in emergency medicine at Denver Health Medical Center. Please give a warm virtual welcome to Dr. Debra Houry. Welcome.
There we go. It finally let me unmute. It kept saying, host won't let you unmute. Great to see you, and wonderful to see so many colleagues. I'm excited to hear Dr. Adams come after me. He was a wonderful colleague that I had the opportunity to work with, as well as with you. And so great to be here. And on behalf of our CDC director, Dr. Mandy Cohen, and our fellow CDC team members that are committed to our mission of saving lives and protecting people 24/7, just want to give a huge welcome and just share the excitement around this topic. So I'm particularly pleased to join you today, as both the substance and the spirit of your work at this roundtable really complements much of what we're doing at CDC as part of our Moving Forward initiative. This ongoing effort aims to transform how CDC operates by refining our systems and structures to really equitably protect the health, safety, and security of Americans. And one of the core components of this work is to promote results-based partnerships. And this roundtable is such a great example of this type of partnership. And we look forward to celebrating the successes that you all will generate in hypertension control. This is such a serious condition that affects 1 in 2 adults in the US, and it needs collective, smart, and immediate action by a diverse set of partners, including clinical and public health leaders, industry, academia, and community organizations. So that's why I'm thrilled to see the composition of this roundtable. Each of you can contribute to the shared aim of improving hypertension control and eliminating disparities and to discover today and in the months to come really how to move this forward and to strengthen and spread your impact by working with others. So the theme for this summit, Racing to the Top, to bring down blood pressure, really conveys the effort and urgency to protect people from the harm that undetected and uncontrolled hypertension causes. You all know that we lost ground in the hypertension control over the last decade, a trend that certainly worsened even more so during the pandemic. And without our collective effort now, this lost progress of blood pressure control rates and exacerbation of long-standing health equities will cause our families, friends, and coworkers to suffer heart attacks, strokes, kidney and heart failure, and complications of pregnancy that are largely avoidable with good blood pressure control. Because hypertension during pregnancy, whether it's chronic gestational preeclampsia or eclampsia, raises the likelihood of a bad outcome for mother and for a baby and the whole family, just having this hypertensive pregnancy can raise the woman's lifetime risk of heart disease and stroke and accelerates its development earlier in life. And we know that there's 116 million US adults with hypertension. So really a lot that we need to address. I just want to say this underscores the urgency of our mission by ensuring the timely detection and control of hypertension. We're investing in healthier pregnancies and brighter futures for all. Given these challenges, Racing to the Top sets the right frame for your meeting today and moving forward. And I know you have a full agenda today, including what promises to be an insightful and compelling dialogue featuring former U.S. Surgeon General and my friend and current Purdue University faculty leader, Dr. Jerome Adams, and Dr. Ezekiel Emanuel, joining from University of Pennsylvania. But I did not want to conclude without issuing each of us a challenge. So please use your precious minutes around the table today to learn from and connect with other members who can help you succeed wildly in your efforts to equitably detect and control hypertension and to protect people from harm. We all know the problem. So let's commit to action and accountability. Each of us has a role to play in advancing equitable hypertension control. And with that, here's to a fruitful and action-oriented meeting. Thank you for the opportunity to join you today.
Thank you, Dr. Houry, for that charge. And at this time, I would like to turn it over to Dr. Janet Wright, who will be moderating a plenary session. Dr. Wright, take it away.
Thank you so much, Dr. Ogunniyi, and the leadership of the roundtable for this wonderful opportunity. I'm not sure if I'm going to moderate or referee, but I am so excited to bring with you and be a part today of a dialogue between Drs. Emanuel and Dr. Adams, two, I would say, international leaders in health, in healthcare, in health policy, who have also been strong and committed advocates for better hypertension detection and control in the country. And so because we are gathered here as the roundtable, as leaders throughout the communities across the United States, and all of us are driven by personal commitment, I want to start with a question for each of you. Why do you care about hypertension? Why is this such a burning issue for you? And Dr. Adams, I'll start with you.
Well, I'll give you a very quick and direct answer. I care about hypertension because I have hypertension. I'm one of the 50% of Americans that has high blood pressure. My mother has high blood pressure. My father has high blood pressure. Both of my grandfathers died from sequelae of uncontrolled high blood pressure, one from kidney disease, the other from cardiovascular disease. So it's something that impacts me as a Black man very deeply. It's something that I feel if I can make even a small dent in hypertension control in my lifetime, then it will pay exponential dividends for other lives across America, even long after I'm gone.
Dr. Emanuel?
Yeah, well, as many of the audience may or may not know, I have nothing to do with hypertension in my regular life. I'm an oncologist. And as we say, cancer cures all diseases, including hypertension. It's not the way we want to get rid of hypertension in this country, however. But a number of years ago, I ask myself, if you had $1 to invest in the healthcare system, where should it go? What's the biggest ROI we can get from healthcare interventions? And if you look over the last 60 years, 70 years, the single biggest thing we've done to expand longevity in America was to bring down blood pressure in the 60s with basic thiazide diuretics, brought down the risk of stroke, brought down the risk of cardiovascular disease, kidney disease, more than smoking. And I think most people, certainly most healthcare people, don't recognize that fact. So I said, well, that's the number one thing. And then we've had all this focus, as was so nicely said at the start, on disparities and the fact that we finally recognize after all these years of knowing about disparities that this has to be a top priority for the country. Again, you address hypertension, you address a major cause of disparities in this country, so eloquently put by Deb, disparities related to renal disease, disparities related to maternal mortality and morbidity around pregnancy and preeclampsia. So, I'm a wonk, and the basic wonk question is, okay, how can you get the most for the next investment? Well, the most for the next investment is hypertension control. And then when you look at the hypertension control in America, this is why I'm bald. You pull out all your hair because it's just so awful. I would have used a 4-letter word, but, my brother advised me against that. It's appalling. We are, at 24% of Americans who have high blood pressure under good control. And that's not for lack of tools, right? We have all the tools. We have cheap blood pressure cuffs. We have agreed upon guidelines for treatment. Almost all the medications, we have more, as I understand it, more than 200 medications for hypertension control. They're almost all generics. This is like a no-brainer, low cost, highly effective. Why are we so bad? We really have to refocus us. And the last thing I would say, Janet, is, and I'm sure Dr. Adams knows this from his time in government. From my time, it's like, you can't pick 27 goals. You can't even pick 3 goals. You really have to focus yourself on one goal and marshal everyone together. When my brother was in the White House under Bill Clinton, he was like, get 100,000 cops on the street, get all those guns and semi-automatics off the street, right? That's your goal, okay? Everyone can focus on that. Yes, we've got lots of health problems in America, but we can all focus on hypertension because it's the biggest return. And yes, diabetes is important. Cancer is important. Far be it from me to say cancer isn't, but hypertension returns the biggest payoff in terms of absolute health improvement and in terms of reducing disparities. So that's why I, have been very vocal about trying to make hypertension the focus of our efforts, because it'll just do more than anything to reduce disparities and increase health in America.
Janet, Dr. Ray, can I put you in the position of referee already? Because first of all, I've got 2 points of contention with Dr. Emanuel. We want to make this exciting. Number one, it's hard for me to believe that it was your brother telling you that you shouldn't curse, knowing what I know about your brother. Number one, but number two, you brought up an interesting point that I think is it's one of these ironies in hypertension control. Most of the medications are generic, and if you want to understand what's going on in the U.S. healthcare system, and this may sound cynical, but I think it's reality. Follow the money. There's no money to be made for a lot of people in controlling hypertension. Cancer, my wife has stage 4 cancer. She's on immunotherapy right now. Her medications are making a whole lot of people a whole lot of money. And so there is a whole team that is committed to calling her, to following up, to making sure she's on her medications. She's getting that oversight over her care because there are people invested in financially her being her staying on her cancer medications, but no one's making money off of my amlodipine that costs $2 at CVS. So I just want to throw that out there to kind of be provocative and to see how you would respond to how do we motivate people in a world, in a healthcare system that runs based on who's making money, to do something that has now reached a point where a lot of people don't see that there's any money to be made out of it.
Dr. Adams, I couldn't agree with you more. The pharmaceutical industry, they know how to get doctors to prescribe certain things. They know how to get patients to comply. And we simply need to take some of their techniques. And I think in this case, I couldn't agree with you more. We need to change the incentive structure. So the incentive structure under fee-for-service is, you get paid for doing more. Pharmaceutical companies get paid for selling more drugs. But under value-based payment, right, it changes. That's the first thing. The second thing is there are lots of organizations that have an interest in actually reducing healthcare costs, and we have to make it clear to them, this is the kind of investment. The U.S. government has that interest because, after all, when people get to 65, they've had lots of hypertension. They're going to cost more. Lots of managed care plans or Medicare Advantage plans, or now primary care doctors, they're going to cost more. I think what we don't have is a clear roadmap. This is my own personal view. What would it take for us to really make a difference? First of all, establishing this as the priority and measuring everyone on it. One of the best things I've seen in the last few years is the California Health Insurance Exchange is going to go to 4 quality metrics in evaluating their health plans. And one of them is hypertension control. I won't say I had a lot to do with it, but I don't think I had nothing to do with it by pushing on this and pushing with the people who were making that choice. That's a very important choice, that this is, like mammogram rate, this is way more important. And again, I'm an oncologist, a breast oncologist, way more important than mammogram rate to get this one right. So I think making it a quality metric, but also I think really, really important is collecting the data on how well we perform and putting it under each group or physician group. If you look at where we've made big progress in this country in major initiatives, like California and maternal mortality, they've dropped maternal mortality by 2/3. How did they do it? Well, they provided a toolbox and they measured it, and they put out those measures and performance publicly. When Minnesota increased its hypertension control, one of the key elements of doing that was measurement and public disclosure of the performance of people. Now, is that going to turn things around overnight? No, but it does turn things around in a short period of time, where short is 3, 4, 5 years. And I think that's the kinds of things we need to be aiming at. The last thing I would say is we need to give doctors and remind them of the guideline and the toolbox for addressing this. Most doctors should not be involved in hypertension control. They do a bad job. I'm just going to be honest about it. This is not something that requires, 4 years of an MD degree, 3 years of residency, however much of fellowship, right? We do have the guidelines. They need to be involved in the tough cases, the cases where, we have hypertension that's difficult to control. But 70, 80%, that's not our issue. Our issue is actually paying attention. And that may not be doctors' best attribute for something which they consider simple and maybe even a little beneath them to really worry about. And so I think getting whether it's nurse practitioners, it's even medical assistants to do this is probably the other thing we need to do. So establish it as a priority, set the goal, give people, remind them about the guidelines and the drugs, and make sure that someone is really paying attention, probably someone other than the doctor. That would be my formula or manual for success.
I love that you mentioned many of the other folks who can be part of the care team and the strategy for controlling hypertension. I was the chair of our pharmacy and therapeutics committee at my hospital for 10 years and helped oversee many collaborative practice agreements for anticoagulation clinic, for diabetes care. And as you mentioned, it was bringing in pharmacists, it was bringing in nurses, it was bringing in PAs to actually do the day-to-day management, the callbacks, the tweaking within those protocols that really helped us improve care so much more than the old mantra of come in, get your blood work, see your doctor, do a tweak, and then we don't follow up for another 3 or 4 months or 6 months or a year. So couldn't agree with you more there. And I think one of the other things that we haven't leaned into enough that really complements everything that you talked about is digital health. We have technology now to be able to pull data on patients, create dashboards that make it easier than ever to identify who's red, who's yellow, who's green. We can focus in on those folks. We can give real-time feedback to our patients and get real-time information from them with Bluetooth digital monitors. So many different ways that we can leverage technology now that we haven't had in the past to be able to have that real-time visibility and accountability. And that information can then feed back to, as you mentioned, to insurers, to payers, to healthcare systems, so that we truly can say, you're doing a poor job, you need to do better, you're doing a great job, without, I also used to run a health department. One of the big challenges is a lot of our data is literally 2 years behind. It takes you that long before you figure out you're doing a terrible job at something. Well, now we can find out in near real time which patients and which practices are doing a good job and which ones need to step things up a bit. Janet, sorry, we totally took control of your conversation here.
I would say one other thing, and you said this en passant, Dr. Adams, but I want to pull it out, which is the at-home blood pressure monitor. So my in-laws, hypertension, and I was like, this is ridiculous. We have high-quality certified blood pressure monitors that are available for $40-50.
Mm-hmm.
And we know that if you've got to come in to get your blood pressure monitor, or you got to go to the pharmacy to get your blood pressure monitor, it's, there are all sorts of barriers to doing that. Time being the number one barrier, transport being the number 2 barrier, right? These are cheap by any stretch of the imagination. Giving it to people going home. Now, at the University of Pennsylvania, something I didn't do, but my colleagues did, is Heart Healthy Moms. And that is, we're going to discharge a mom who's at risk for high blood pressure. Instead of saying, come in twice a day to get your blood pressure measured, which the compliance rate was in the single digits, we're going to give you a blood pressure monitor. You're going to go home and we're going to ping you on your phone through text messaging to take your blood pressure twice a day, report the results. And if it's high, then you come in. That's the kind of thing we need. And, it's, again, just thinking about the cost, 100 million people, $50 a blood pressure cuff. We're talking about $5 billion. Oh, $5 billion, everyone. We spend $4.3 trillion on healthcare per year in America, $175 to $200 billion on hypertension problems for healthcare. We can do $50 a person, $5 billion. And it's not like these things blow up after 1 year. This is another really important point. And I think, again, going back to your original challenge, Dr. Adams, if we switch the mindset from, fee for service to value-based payment, it becomes worth the practice's investment in that blood pressure cuff if they can forestall emergency room visits or strokes or hospitalizations because of high blood pressure. And that's the kind of mentality, preventing complications, that we need to instill here.
We send every mom home.
Okay, you do.
We send every mom home with a crib, with a car seat. We make sure they have them, and we will pay for them to go home with them if they don't have one. I love that. I love the idea of sending every at least at-risk mom, if not every mom, home with a blood pressure cuff, because heck, that's a way. It's not any more expensive than a car seat or a crib, but it's a way that we can save lives moving forward. All right, Janet,
I can see you, Dr. Adams. I can see that you have not bought a car seat recently. I haven't either, but I am a grandfather, and I can tell you, $50 doesn't even get you the buckle on a car seat these days.
I will say he may not have bought a car seat, but he does have a remote monitor. He does have a blood pressure monitor. I know
I do.
that. So thank you to, I would like to close with, maybe you could issue a charge to these fabulous roundtable members and all of their networks. Dr. Adams, I'll start with you.
Well, I'll be brief, but two quick things. Number one, it takes a village to channel Hillary Clinton. We need to make sure we're creating an ecosystem around folks that is supportive of blood pressure control. Everything from taking into account transportation barriers to childcare barriers for appointments to access to health insurance. We need to create that context that makes the healthy choice the easy choice, makes it easy for people to monitor and control their blood pressure. We don't want to forget about these social drivers of health, including exercise and diet, that impact our ability to control blood pressure. It's not just all about pills. And number two, we need to understand that good health is good business. Why do I say that? Because I put out not just a hypertension call to action, but also a Surgeon General's report on community health and economic prosperity, making the case that employers and businesses can play a huge role in improving health, specifically improving control of hypertension. They can make sure hypertension control is an important part of the benefits offered to their employees and members. And you heard Dr. Emanuel talk about accountability. Well, employers should be asking, what are the hypertension control rates of the practices in the healthcare systems that we're funding through our plans? They can make hypertension control friendly work environments where you can monitor your blood pressure at work, where you've got healthy food choices, where you can exercise, where it's easy for you to get your prescription filled, either because it's sent to your house or because you have paid time off to be able to do hypertension control follow-up. Good health is good business. And I posed a question provocatively to Dr. Emanuel earlier about where's the money to be made. But we've got to understand that there's a tremendous amount of money being lost by these employers because of their failure to control hypertension. So they need to do it, not just because it's the right thing to do, but because it's going to actually make them more competitive in a global marketplace if their employees have their hypertension under control and they don't develop kidney failure and they don't develop cardiovascular disease and they don't have maternal morbidity and mortality.
So two things. The first I would say is in your local community, your local healthcare facility, I would urge, we're going to measure, get the senior leadership. We're going to measure blood pressure for every single one of our patients, and we're going to measure the performance of our clinicians and feed that back to them with measuring them against other people. We know that works. We have lots of behavioral economic evidence and lots of other context to know that collect the data and give people performance feedback on how they're doing and how they're doing compared to other people does work. And that, I think, if I were individuals with any organization, whether it's a health system or a public health community or running FQHC, that's the initial intervention I would do. The second thing, and here I would dissent a little from Dr. Adams, it's not that I don't think employers should be involved, but I wouldn't rest on employers. They're incompetent in healthcare. They have never moved the needle on healthcare. It's just a fact. They view it as a cost issue. They do not view it as an investment issue. And there are lots of reasons for that. They don't keep their employees a long time to see the products of their investment. So I'm not sure I would spend a lot of effort. I think it's a good thing they should do. And if they structured their healthcare right, it might actually be beneficial to them and to their bottom line. But they're not that smart. And so that's not where I would personally put my effort. I'm quite cynical about employers. They talk a big game, they worry about all the costs, but they don't do the right thing. And there's lots and lots of evidence to that effect. Measure and give performance feedback. I think those are would be my initial investments. Thank you very much for this, and really appreciate all you do to actually make America healthy and to reduce the disparities. I wish people would just listen to you a lot more.
Thank you both. It is a crime to wrap this up, but we are so grateful for the time you spent with us today. You've inspired us all and driven us to even greater action. Thank you so much.
Take care.
you. Thank you.
It's my pleasure now to introduce Q. Probably doesn't need an introduction. We're so proud to have him as a member of the Roundtable and is now the CEO of the National Association of Community Health Centers and a leader for a long time in hypertension. Q, turning it over.
No, thank you, Janet, and thank you for that great dialogue. I'm grateful for the opportunity to talk to all of you and be a member of the Roundtable, and I'm excited to kind of share a little bit about a framework that I've been fortunate to leverage in my my professional career from a primary care physician, serving in National Health Service Corps, community health center settings, and then so working in the nonprofit sector, the public sector at HRSA and NIH, where I had the great chance to work with Zeke as well, and then working most recently in the private sector at IBM and CVS Health, and now being very proud to serve as a CEO and president of the National Association of Community Health Centers. A framework that I'm going to share my screen. I'm going to make sure you guys can see it. You guys see it? And I'm going to start.
We can.
All right, perfect. So I do want to do a shout out to two of my colleagues who are on this call, Dr. Ron Yee, the CMO of NAC, and also Meg Meador, who's the Director of Clinical Integration and Education, who you'll hear from a little bit later. But as I reflect on the opportunities we have with this great group and with the Roundtable, the importance of thinking about how we leverage the 7 Ps of the health system, which I'll reference here later, and with a very focused area on just the example of validated blood pressure measures. So let me just move here. I would be remiss if I didn't talk about what I believe is the best part of our U.S. health system, our community health centers. They serve 31.5 million Americans at over 15,000 sites. They're the largest primary care system in our country. And I think they're also the most diverse and most innovative part. And they are working hard to deliver blood pressure control. And you can see the diversity of the people we serve. Over 40% are rural, 64% are minorities. And just very grateful to be helping lead this movement with over 300,000 people out in the field. So much of what happens in blood pressure prevention, detection, and control is focused on what I would call the 7 Ps. And as Dr. Emanuel and Dr. Adams were talking, I was reflecting on, the perspectives that I've been able to have. I've been able to serve as a CMO of the 3rd largest health plan, Aetna. I've been able to, serve as a CMO at HRSA, an agency that I'm very proud of in terms of the work it does for underserved communities. I've been able to serve as a primary care doc, as a provider. I've got family members who have hypertension. So in many ways, as a large employer, I know Dr. Emanuel wasn't a big fan of employers, but I believe employers have done some creative and innovative things, including IBM as an organization, helped start the Primary Care Collaborative and helped the movement in PCMH, patient-centered medical homes. So to me, all these stakeholders have an important role in improving our U.S. health system and how they work together, how they're often siloed, how they're often not talking to each other or leveraging the same data sets, how their incentives are built. In many ways, if you follow these 7 Ps, you can also see where the money and the data flow in our health system. And so I'd like to start as we think about blood pressure control and validated blood pressure devices. This was not something I knew about as I had family members with blood pressure, and I remember buying devices and as a physician in the early 2000s and not recognizing that that these weren't necessarily validated. So this is an important topic, and you should go to validatebp.com to see kind of the history and the story here and the work the American Medical Association is doing around assuring that the devices that are out there are validated. But just consider the dynamics of a patient and a provider first. So as a primary care doc, as an internist and pediatrician, I'd be worried about hypertension. It would be a vital sign that I'd check, and I'd worry about it for the patients that I served. Devices I had in my exam room were validated. We had a whole process of calibrating those devices and checking that they were accurate. But as you think about home devices and, with the opportunities that we have for home monitoring and devices at home, who gets those devices? Who buys those devices? Often caregivers buy them for their family members, or the patient will. But making sure, the patients know that there's an importance of having validated blood pressure devices. Providers also, as they recommend you to go get a blood pressure device, are they making sure that the devices they're recommending are validated, or are they helping, that patient in that plan? And I remember a lot of patients with hypertension that I served that, I told them to go across the street, the CVS, to buy a blood pressure device and take a blood pressure diary. But, the reality is many of those devices that are being sold haven't necessarily been validated. Payers, I know at Aetna, I push for the policy that we need to make sure when we covered blood pressure devices, which we do have a policy that covers them for people with hypertension, that the devices had to be validated. And that, the link to validate BP, and in order to get that covered or reimbursed, that was a key criteria. Purchasers, I believe, they can see their data. As an employer, I saw it for the over $1.3 billion in spend that we had just for the U.S. employees, non-retirees, and there was a lot of expense on hypertension and heart health issues. And so employers actually could create a policy. There are policymakers themselves that say, we want to cover, blood pressure devices at home, and we want only validated ones. So I do think in our US system, the 160 million Americans who are under employer-sponsored insurance have quite a bit of influence over deciding what is or isn't covered, including devices at home, and making sure they're validated. Policymakers, as you think about Medicare and Medicaid policies, there are many examples, at a state level where, blood pressure devices have been covered. For Medicaid, clearly, as we think about community health centers, we worry, about the Medicaid policies, particularly with 50% of our population who are Medicaid and 10% who are Medicare. So, and 20% who are commercial, often through the exchanges. So I can't underemphasize, the importance of CMS and state Medicaid agencies in making sure the devices that are covered, one, should they be covered at home, and two, that they're covered and they're validated. Producers or product manufacturers, the people who make those devices that range in price from, $20 to $200, are they going through the process of making sure they're validated is important. And then the last category, I kind of put in a miscellaneous category. I think any of these P's can be pioneers. They're often trying to improve the system, but often, academic institutions, researchers, digital health entrepreneurs, even if you look at kind of private equity backed kind of initiatives, people are trying to challenge the system and the status quo. And I would view the National Hypertension Control Roundtable as a pioneer. How are we thinking across all 7 of these P's? How are we trying to assure that our health ecosystem is aligning with the purpose of empowering patients with home devices that are validated? And so thinking across this ecosystem is incredibly important. Last slide I'll reference, going back to what I'm so proud of, having served in community health centers, having served as a National Health Service Corps scholar, having served also as a chief medical officer. The work that we're doing at NAC is definitely in line with these 7 Ps, and with a particular focus in the partnership we have with the CDC around Million Hearts, the work we're doing for our patients, 31.5 million Americans, many of whom have blood pressure control challenges and issues. I'm very proud of the fact that our national report, most recently our quality report, showed that our blood pressure control was at 60%. while national averages were 50, so we're more than 20% over the national average. I'm very proud of the work we do to enable providers with tools to help choose a blood pressure monitor, but also making sure they're validated and making sure, you know, we're helping people with their blood pressure control challenges and issues. And then I do believe we're pioneers in many ways. We're the best part of the health system, and we've been innovative. We continue to be very MacGyver-ish with limited resources to deliver care and health equity for those 31.5 million Americans. And we're also probably the most diverse part of our healthcare system. And there's no question we need to represent the people we serve in our healthcare system. That's all I got.
Thank you, Q. And I should also mention that you are one of our steering committee members and a huge support and an expert really in all that you do. So I just want to personally thank you for all of your support, and also want to mention that you and I have been working out on a paper that we hope to publish, wink, wink, soon on the 7 Ps. So thank you so much for your time. So moving right along, I am now going to introduce one of our co-chairs, Dr. Jaime Murillo, who is the Senior Vice President and Chief Medical Officer at United Group Strategy and Innovation, and he will be introducing our panelists to talk about something that we launched last year after our last annual summit. So Jaime, take it away.
Thank you, Jenny, and thank you, Q, for such an inspiring conversation about all the stakeholders. And that's what we at the National Hypertension Control Roundtable aim to achieve is one is action-oriented, but that action-oriented cannot happen without including every single one of the stakeholders. And blood pressure is more than just a number. It really is a team effort. So we are very excited about doing this, following this presentation with Payers Task Force meeting, and tell you what the experience has been like doing that. The reason why we ended up doing this work was because we started this conversation around, you know, are the payers, you know, should they be a vital part of it? And should they be, maybe we can have a very focused conversation with the payers in this regard. And we started talking to them about, you know, what if we meet on a regular basis, talk about
hello everyone, and thanks for joining. My name is Dr. Dominic King, and I lead the Center for Advanced Clinical Solutions.
Sorry, is that for a moment I got a conversation going there. So let me just make a quick introduction. So we'll start with Dr. Margolis. Karen Margolis, she's a senior researcher at the Health Partners Institute. She's in telemedicine as well. And she has studied a variety of medical issues, including the safety and acceptability of flu shots, screening for breast and cervical cancer, preventing falls and fractures in older women, safety and effectiveness of postmenopausal hormone therapy, diabetes, COVID, you name it, and has been a very strong advocate and verbal leader in our Payers Task Force, including writing a paper about putting a business case behind, you know, why it's important to control hypertension and what's the business case behind it. So that's one of our panelists. And then we have also Nar Ramkissoon. He's a senior manager of ecosystem development with improving health outcomes of the American Medical Association. Nar leads partnerships, programs, and policy efforts to increase innovation and access to cardiovascular disease prevention for physicians, care teams, and patients. He works with both public and private payers, employers, and other stakeholders. And he's obviously focused on hypertension with the support of adopting telehealth, SMBP programs as well. He actually leads what you hear about the U.S. blood pressure validation device listing, which is a resource for physicians and patients to identify those blood pressure devices that are validated for clinical accuracy. So we'll hear more from him. He also has a background in public health. And finally, Scott Film. Dr. Flynn is the regional medical director at Blue Shield of California, where he's focused on improving the value of the care delivered to its members. He, prior to joining Blue Shield, he was CMO of Arch Health Partners in San Diego. He's also a 22-year Navy veteran and was part of the Navy SEALs. Impressive. Medical director in a Naval Hospital San Diego, and the surface forces surgeon in charge of all the healthcare on Navy ships worldwide. He's a graduate from University of Pittsburgh and certified in family medicine. So with that STEAM panel on board, let's start the round. Let's start firing a little bit. So each one of you, please tell us, why you're participating in the payers task force. Why is it important to you? What are those moments you said, I didn't expect this from this meeting, from this group? So let's start with Karen.
Thanks for the introduction, Jaime. I guess the main reason that I have been enjoying and decided to join the payer task force, even though I work for a health system that includes both care and coverage, I, as a physician, feel a lot closer to the clinical side of things. And I wanted to understand more about the payer perspective. And I think it's been really, really helpful for me to be part of the payer task force to understand the different forces that are working on the insurance side of the business.
Thank you. Nar? You're the news member, by the way. You're not, interestingly enough, people may be wondering, wait. Oh, he's coming from AMA, he's in a payer task force. Well, the reason was we included now was because his work was directly correlated with the work that we're doing in the payer task. So we wanted his input, but he also wanted our input. So he has worked. So Nar, tell us about that interaction with the panel, with the task force.
Yeah, thanks, Jaime. And again, I'm very excited to be a part of this task force because, it is the direct line of communication, to the payers, and helps get, that additional perspective, but also gives us an opportunity to share, that provider perspective as we, look at these issues. And I mean, what I'm really surprised about is just how action oriented, this group is. I mean, we're not just talking about, these challenges, we're actually agreeing on, what needs to get done, taking those next steps, and like quickly engaging in addressing some of these challenges. So yeah, definitely surprised and excited on how quickly things have moved within this task force.
Great, I like that. Dr. Flynn.
Yes, good morning. Thanks, Jaime, for the introduction. Just clarify, by the way, I was a doctor with the SEALs. I was not a Navy SEAL, just to make sure everyone knows that and doesn't go running off saying, "Oh, I saw the SEAL today." Anyhow, the reason I'm engaged in this is obviously a personal story, sort of like what Jerome was talking about. I have hypertension, but my wife's grandfather died of uncontrolled hypertension with a stroke at a relatively young age, and it was criminal to see that. But then as you look around, you see that our national control numbers are 50% or just under that. And in the richest country on earth, and I believe Dr. Adams alluded to this also earlier, how in the world are we less than 50% control for hypertension, and we're spending billions of dollars on all these other things in something that's really a silent killer? So it's huge motivation, and it's something we can actually do something about. When we look at implementing best practices, some of our provider partners are able to get 80% control or above, right? So it is achievable. It's just how you focus on it and how you do it and implement those things. Jerry Penske was also on the call, was one of the leaders in that also, and promulgating those best practices. So it's a passion project and also something that's achievable if we do the right things.
Excellent. Thank you for sharing your perspectives and the whys. Now, Nar, you've been working on this concept of lately about the AMA's validated program. I bet some people in the audience, even though this is a National Hypertension Control Round Summit, may not be as familiar as you are, or some of us may. Could you please just tell us about it and tell everyone about it, and not just what it is, but where do you see its application and the long-term impact of adopting such a practice?
Yeah, that's great. And I know folks heard a little bit about it from Dr. Houry about talking about validated devices and the 7 Ps. So our role here at the AMA, we actually wanted to address this issue around understanding which devices out there on the market have been validated for clinical accuracy, And again, with all the different devices out there, it's very hard to tell which ones have been validated, especially as we look at the clinicians, the care teams, the patients. We really wanted to simplify the process for those folks, because that's really what's going to help drive change and impact. So what we did at the AMA is we actually developed and launched the U.S. blood pressure validated device listing. We wanted that to be the resource where these folks can go to actually find a list of devices that have been validated for clinical accuracy. These devices have to go through an independent review process where there aren't any conflicts of interest. We want to be a very credible, transparent, objective process so that folks have confidence that whatever is listed on the website has actually gone through independent review for accuracy. So we want to make sure that there's trust and confidence in those devices, because that's what's going to result in uptake. So this website is publicly available. It is at validatebp.org. I encourage everyone to check it out. I think a lot of folks play a role in the selection and the purchasing of the blood pressure devices. And that's really, again, what's going to drive that change if more folks are actually going out and getting and obtaining validated devices over non-validated devices. I definitely encourage everyone to check it out. We actually just launched or released an update to the website just yesterday. So it might look a little different to those that are already familiar, but it just, again, makes it a lot easier to navigate, makes it easier for physicians to recommend specific devices to patients, and hopefully makes it easier for patients to kind of compare and contrast devices as they go through it and consider which devices to actually buy. So again, the more folks that are aware of the VDL, that actually access it, that either compare their devices to what they own already or use it as a reference to buy new devices, that will hopefully lead to more validated devices being used out there in the marketplace, both again for home monitoring, which is growing, but then also just as your office device, just what's being used in the exam rooms as well. So accuracy is important in all settings for all people, and definitely hoping that access to this resource will drive some of that action.
Excellent. Yeah, thank you. Very well said. And for those of you, in the audience, now you have a tool that could be potentially used in many settings. Maybe in a few words you can describe in the chat, how do you see utilizing, for instance, VDL as a tool to improve care? Could be done within your own organization, your own setting. So it's good for us to start processing, not just getting the information, but also what do we do with it? Karen, you've done a lot to raise awareness of hypertension and health partners. Tell us, how is that working? Is it working? What else needs to be done? What have you done that you think is valuable for us to learn from?
Well, first, let me just say what a fantastic upgrade the VDL got a couple days ago. I noticed it right away when I signed on, that it would tell me about what were the features of the monitors, the various cost comparisons, what populations it's been validated for. So I'm so excited about those upgrades and the ones that are to come. At Health Partners,
that's without charging for the subscription. Great.
At Health Partners, we've done a lot of testing of home blood pressure telemonitoring and pharmacist care management, and that's, I think, a very potent combination. And we're working on trying to roll that out and get that to be at least an alternative model of care that's being used side by side with the more traditional face-to-face bricks and mortar titration by physicians methodology. And it's a bit of a slow uptake. I think one of the things that being on the payer task force has really driven home to me is that oftentimes I think executives at health plans, present company accepted, they're very knowledgeable about the measurements that they need to do, but maybe not necessarily versed in the latest details of epidemiology. And I think one of the things that I've really realized is the need for kind of emphasizing really just how high of a priority hypertension control is relative to all the other things that that health plans need to worry about. So, for example, I just heard a presentation given by some of our leadership about the work that they've been doing on cancer screening, improving uptake of that, and the health equity piece of it. And the reality is that we have just as big disparities in hypertension management, just as big of a problem with our measures not being where we'd like them to be as an organization, and yet probably 3 to 5 times the population health impact in terms of mortality than you get from cancer screening improvements. So I think trying to get that message home about the enormous health impact of improvements in hypertension management, and how that should be really top of mind for all of our health plans. So that's been a big realization, and I'm working on that within my own organization, and recognizing that it's a bit of a slog. It's just hard to get people to change how they think of things, and to add new measures, or to say this is we're all in on this and this is what we have to do.
Great. Well, thank you for sharing with us, Karen. I'd asked you, all three of you at the beginning, what your experience has been like, but I didn't ask myself, so I'm going to ask myself. Jaime, what was your experience in the task force? I have to say probably what has impressed me the most is the candid conversation we've had in those meetings, without revealing any confidential information from my own organizations, but it's just how we have exchanged our own experiences and for the others to learn from, or good experiences or best practices. For instance, I said, "Oh, I never thought about that. I'll talk to my internal people about this initiative," and so on. So that to me has been one of the best parts, if not the best ones, of these meetings, is that we exchange information, we learn from each other, and then we take those learnings to our own organization. So that's what I'm essentially doing, is try to appeal to others who may be in the audience or may not be, but to join our task force, because it really is enjoyable, but it's also extremely cooperative in a really learning experience. Scott, let's move on to you. So what's in your group and the work you've done around blood pressure control, within the capabilities and your possibilities, understanding that there are some restrictions as well within an own organization, what you feel like you have accomplished? What are your next steps in terms of blood pressure control within Blue Shield in California?
Yeah, thanks again, Jaime. The big thing that we're doing, and this was alluded to earlier, Covered California has picked 4 measures to work on in terms of what they're emphasizing, and actually putting real dollars at risk for health plans, up to 4% of our healthcare premium, which is a big number for those 4 measures. And as alluded to, they include hypertension control, diabetes control, CIS-10 immunizations, and colorectal cancer screening, and the other 3. But with that added emphasis, we have an even more sense of urgency to work on this, in addition to the fact that by controlling hypertension better, you can meaningfully decrease strokes and heart attacks within a relatively short period of time. That was alluded to earlier. I believe also that by working on a hypertension, within a couple years, it's 2 to 3 years, you can actually get a meaningful reduction in those. Most people think it takes decades. It doesn't. So getting that message out there, why there needs to be a sense of urgency on this, and why it's important. Again, it's not hard necessarily to do for most patients. Everyone talks about that difficult, hard to control patient, but in general, there's that other 30-40% that's not controlled, that is not a difficult control. It's just inertia, lack of a sense of urgency. We talk about promulgating these best practices now. We've reinvigorated with the Right Care initiative and what's called the Be There campaign in San Diego, which is the originator of the Site for Right Care with Jerry Penso and Hattie Hanley, and getting those best practices out there that include getting leadership buy-in, publicly reporting hypertension numbers within physician organizations. Providers are motivated not just by money, but also by peer pressure, peer review. Because what doctor have you met that didn't think they were at the 90th percentile for everything? Right? They all do, right? And then when you show them the numbers and they say, "Oh, look at that! That's and I'm only at 60%, and my buddy down the street is at 80%." So that tends to motivate the folks. The other one we talk about, and this was mentioned earlier too, is inertia, and using collaborative practice agreements with pharmacists or pharmacy techs to get folks doing that rapid med intensification to get blood pressure under control in a short period of time instead of the usual care, which is, "Oh, I'm going to diet and exercise," and they come back 6 months later and it's still not controlled, and they get on just a hydrochlorothiazide 12.5, and 6 months more go by, and then they get up to 25. Next thing you know, you burn 2 years and they're still not in control. Do that rapid med intensification. So those are the kind of best practices we're pushing out there and getting our groups engaged and putting money at risk for them, both on an upside and potentially downside with our contracting. So that's what we're really engaged in right now on a practical basis and trying to improve these numbers.
Great. So I'll add a note there. Thank you, because you gave us a lot for us to think about it. And that we're going to talk down the road a little bit more. Diane is leading a program about the business case, but obviously being a payer task force meeting, we need to talk about money. But let me just, before saying that, you mentioned providers, health plans are not just motivated by money. I would say people will be surprised, and that's coming from someone who was in the bright side and now is in the dark side. It is amazing the amount of mission-driven and caring people we find in health plans or payers. It just we all think that it's all about money. The reality is people really care, and there's a lot of talent. There's a lot of data. So there are a lot of good elements, and that's why I think partnering is with other stakeholders is just a natural part of the process, because at the end of the day, we're all mission driven. We all care about making people helping people live healthier lives, and then but we also need to be part of the reality. And the reality is, how do you sustain those efforts, and how do you create a model that is financially viable? I think we all can agree that what we're doing today is not sustainable, in both operationally and financially. So how do we change that model? And so, if you have an opportunity, you don't have to be a payer, but you can start measuring things like, as Scott mentioned, this heart attacks, any hypertension related complications. I would even go beyond the heart attack and strokes. Why? Because sometimes it takes a long time to demonstrate the benefits, but there are at least 15 different hypertension related complications that you can measure from the outcome standpoint. Peripheral arterial disease, chronic kidney disease, one of the most common one, heart failure, and so on, or even procedures like angioplasties or stents and bypass surgeries. And so when you start putting that business case together, then you'll be able to show your own organizations, whether it's a healthcare system or a health plan, the benefits of it. So that's one. And the other one is measuring other metrics like utilization for emergency room visits. If you control the blood pressure, you're going to prevent those visits. You're going to prevent and avoid hospitalizations that are costly. A single blood pressure, a hospitalization for heart failure or stroke is not less than $18,000, $22,000. And for a stroke, not even adding the rehab and all the lost income. You probably saw some papers in JAMA showing that a person who has a stroke loses $13,000 of revenue in a year just because they are unable to work. So there's plenty of information. We just need to put it together to put a business case behind it. And I haven't even touched stars or HEDIS measures and so on. So there's a lot of it. And Scott, you alluded to the metrics that now are putting the health plans in a bind. So what you see, and I'm going to finish this portion, but what you see is the health plans becoming more operationally active in partnering with the providers in healthcare systems and so on. So there's a need to move forward toward the front altogether, as opposed to staying in the back. Nar, how do you see this in your view, now that you have been exposed to this task force? How do you see this interaction coming forward, and what advice would you have for other parties that have said, this is how we need to engage people and so on, from the at least from the AMA standpoint?
Yeah, it's great. Again, this payer task force has really been insightful. We've had like great discussions on a number of different topics. Validated devices has come up as a key topic as well. And yeah, to your point too, like how can we better partner with providers, leverage provider networks, member networks to start to integrate some of these plans that for strategies that payers can really put forward and implement. So I think that's going to be just an important piece as we think about just how a payer could adopt or provide a suite of solutions. Could be hypertension management programs, hopefully validated devices, and shifting towards value-based care. I think all of those are going to help drive the needle. But to your point, all starts with some partnerships. We want to take care of the clinical aspect first, but also the rest of the ecosystem to remove barriers to that physician patient relationship. So I think bringing all the pieces together is going to be essential to get to the impact, and payers can play a huge role in it, but it does take a village, and others need to participate in it as well.
Couldn't agree more. Karen, are you aware of health plans? Let's just focus on blood pressure devices. The cover for blood pressure devices is that something that depends on what the type of coverage you have, whether it's Medicare or commercial or Medicaid? What are your thoughts about it? What can you share with the audience?
Well, I'd like to be corrected, but I think it's pretty unusual for commercial plans to cover blood pressure devices of any kind, validated, non-validated. The NAR has made me aware that the AMA has some information state by state on Medicaid coverage, both amounts and the types of devices that are covered, which is pretty helpful. I learned from that the state of Minnesota allows up to $75 for a device. But in a lot of cases, the vendors for those devices are not offering validated devices because the non-validated devices are considerably cheaper. And that's the same thing I've also observed as a Medicare Advantage patient or member myself of my own organization, is that we do get a benefit from Medicare Advantage of an X amount of over-the-counter and device coverage per quarter. But the only device that's offered is about a $25 to $30 non-validated device. So I think those are things that there are places where coverage exists. And I think if we can push those, and typically the Medicaid coverage is not for validated devices. It's really especially important for monitoring hypertension in pregnancy. So I think there's a lot of room for making sure that the coverage increases, but that it also is there for validated devices. I believe that the Veterans Administration does distribute or allow for devices as well as for telemonitoring, and that's a hugely important program for the veterans. So that's what I know. I'd love to hear more about information that others have about that topic.
Yeah. So you're asking Scott? Is that what you're saying?
Or people who are participating in the call in the audience in the chat, which I can't see right now.
Yeah, we actually cover blood pressure devices, but our nuance is it's actually covered through our PBM, which you may have heard in the news. We have a changing relationship going forward with, but their list of covered blood pressure devices includes both the validated and unvalidated. So it's a kind of a mishmash of things there. So they are available, but they're not preferred anyway. And trying to work through the bureaucracy to try to get that fixed is proving to be a little bit of a challenge for us. But so they are there, just not all validated.
Yeah, so it sounds like we definitely have a challenge in front of us. And I can tell you that not just this payers task force, but in general, the National Hypertension Control Roundtable is committed to working on that side and that aspect, which is what is the right blood pressure cuff, including our size. They should be validated. We could try to connect the different stakeholders. Is the online vendors and the retail stores selling? Should they be selling the right device? Should the health plans be covering the right device, validated devices? Should the providers know when they recommend one that it should be specifically recommended, validated one? How can we ensure that that's covered? Because when you put a patient who is struggling financially and said, hey, here's a $25 device, not validated, but hey, it measures your blood pressure. By the way, it's in the wrist as well, as opposed to, we can cover that, the proper device for you, so they don't have to choose between the cheapest one that may not give them accurate measurements and the other one that is better. And you heard Dr. Adams talking about smart ones. So that hopefully that's something that we can aspire to, is having the ability to connect those readings to the provider on a timely basis, so we don't have to wait 3 months. And then we all recognize the importance of measuring the blood pressure at home, as opposed to measuring in the hospital. So a lot of work to be done, but again, it can only be done in partnership with all of us. I'm going to end with asking each one of you any last minute comments, advice that you have when you want to pitch your colleagues at other payers. Hey, join us. What would you pitch? And now from your standpoint, what would be your pitch to join us as well?
Yeah, I can start. Yeah, I mean, I definitely think that certainly payers have wide reach. They can impact a lot of lives, and I think that just equals huge opportunity. So I'd say to other payers out there, definitely join us here in this effort. Embrace partnerships that focus on hypertension, and really take a look at the whole picture. Look at your medical policy, look at access, equity, working with your vendors, suppliers. There's all these different relationships that can be leveraged, and certainly start working closely with your provider network, your large healthcare organizations that really want to make impact with their patients with hypertension, and really view that as a partnership. See how we can drive incentives, drive action, make things a lot more available for patients in terms of like medications. So all of that's going to be very, again, impactful, and payers can play a pivotal kind of champion role in this effort. And I know we've talked about this before, but also leveraging the community. There's a lot of community engagement, community initiatives happening across the country. How do we make sure that payers and all the other key stakeholders can play a role in that? I think all of those experiences can all be brought to the fold on this task force and on this roundtable to really, again, bring it all together and make it all work.
Awesome. Thank you. Karen.
Well, I've already pitched one of my colleagues, and she's been on the call. And what I said was, it's not a lot of work. We meet roughly quarterly, and a lot of work gets done, behind the scenes, between meetings, and it's a very productive and engaged group of people, and it's a great place to get different perspectives on what's going on in different health plans than our own health plan. So that's the pitch that I would make and did make.
Great, thank you for doing that and having done it. Scott?
Yeah, two things. One is that 80% hypertension control is achievable, and we need to look at different ways to do it also. In addition to doing the best practices, if we're not addressing healthcare disparities, we're never going to get there. Disparities are a huge, important part of this, and I think everyone's aware of the imperative to do that globally. So that helps with your diversity and how you're going to work on health equity. The second part is that it is actually cost effective, at least based on the publication we did out of San Diego that Hattie and Jerry helped with, that showed that by this 2 to 3 years of reducing strokes and heart attacks and getting better hypertension control, you actually have a fairly significant cost savings that's available there. So there is some literature out there that says, yeah, you actually can get an ROI on this, which, as we know, is something health plans are always looking at as any businesses. So that would be the two things I would put out there.
Great. Well, thank you for that contribution. I'm going to, we see in the chat a couple of questions. Let me just start with one. One of the question is, plan payments for pharmacies, management of hypertension? Are you aware of that kind of plan?
I can take that. So in California, there is a move afoot and some legislation that's been passed to be able to reimburse pharmacists for their time. So that is a thing that is coming and hopefully can help with these work, especially with collaborative practice agreements and other ways to help get other folks engaged in working on hypertension control. It doesn't have to be the doctor as the hero. There are other ways to do this and do it well.
Excellent. Well, I think we want to be on time. Want to make sure everybody has access to their needs. Thank you so much for attending this panel. As you can see, it was informal, but at the same time practical, and we wanted to get some messages to all of you. So thank you for being part of it. Thank you for being a stakeholder here. We know this is the low-hanging fruit, blood pressure control. Then equitable will have the most impact. So there's a lot of good work to be done. To quote Modele when she started, how are we feeling? So I think in general the idea is, we're not happy with how we're doing the job, how we've done the job today, but we're optimistic that we can have it done. So I'm going to now pass it on to Jenny, and thank you for sharing with us your time.
Thank you, Jaime. And of course, as it is, I'm having internet issues. So can you all hear me? I want to make sure I'm not cutting in and out.
Yes.
Okay. Okay, great. Okay, well, thank you so much. And just a reminder that we invite anybody else to join the payer task force if you're a payer on this table, in this meeting. And also, if there's, we will continue the payer task force. We will have additional task force that we're going to be launching later this year. But I just want to also mention that 2 wonderful documents did come out of the payer task force. One, a paper that Karen wrote that we're publishing right now on SMBP and why it's critical that health plans drive SMBP programs within their own organizations and their communities, as well as a wonderful document that NAR put together in response to our payers asking NAR for additional information to speak from the language of business, if you will. So we can also share that as well. So we've already created 2 documents that we will be pushing out and look forward to continuing to create toolkits and resources. And as Jaime mentioned early on, having those incredibly candid conversations in a trusted, safe space among all of our payers. So thank you to my wonderful panel. Thank you to all of my payer task force members, some of who are on this meeting as well, but may not have been on the panel. I so appreciate all the time you have all put in over the last year and look forward to continuing to work with you in the future. So I am going to very briefly give an update on the roundtable itself. I'm going to try to share my screen. Hopefully you will all still be able to hear me. Okay, so quickly, for those who aren't as familiar, this is our mission, vision, values. Nothing has changed since last year. As Jaime mentioned and Scott in the inequities, one of our values obviously is laser focus on advancing health equity. Our vision is so simple, but so profound to me, is to extend healthy life for all. We heard about Dr. Adams talk about it. We heard from Q talking about it. That is really what drives us, is to extend healthy life for all. So what have we been doing since the last summit? Well, we launched the Payer Task Force, which you just heard some of our members talk about. We've hosted 4 fireside chats. Those are on our YouTube site. So if you want to check them out, those are on hot topics from SMBP all the way to Alzheimer's. And brain health and how it's related to hypertension. They're incredible conversations that we've had in the last year. We are going to be launching another series of fireside chats. So if you have a topic or a program you would like to talk to me about, I invite you to come reach out to me. We had our in-person meeting, the first since 2019 for our steering committee members. We were all able to come together for a day and a half in DC and really talk about, how do we strengthen the roundtable? Who is missing at the table? How do we, to Q's wonderful vision of the 7 Ps, how do we engage all of those different sectors? Because we know everybody has to be at the table for us to truly see sustainable change. We added 3 new steering committee members and an off cycle. Part of that conversation, when we realized that we were missing some key individuals and organizations, we reached out to them and invited them to join our steering committee. We added over 50 new members. This is from some proactive outreach, as well as people finding us on the web and reaching out to us through our fireside chats or some of our activities. So we're so incredibly excited that we added an additional 50 members. We wrote 4 papers. So in addition to the 2 papers that came out of the task force, we also wrote 2 additional papers that we're hoping to publish, one of them being the 7 Ps that Q and I have been working on, another one, a manuscript from the key themes from last year's summit. And we had an election among our steering committee members and have a new co-chair. So very quickly, these are our current co-chairs, Dr. Jaime Murillo, who you just heard, and Dr. Modele Ogunniyi, who kicked us off, and you'll be hearing from her momentarily. As you all know, our co-chair position is a 2-year term, and one person rolls off every other year. So I just want to take a pause here and thank Dr. Ogunniyi for her incredible expertise, advice, availability, for everything that she has done on behalf of the roundtable. I speak to her on a regular basis. She is always there to answer my questions and to provide that insight. So thank you, Dr. Ogunniyi. You're not going anywhere yet. I still have you until December, and you'll be on the steering committee. But I just thank you so much for your time. Our next co-chair will be Dr. Yvonne Commodore-Mensah, who is the Associate Professor at Johns Hopkins School of Nursing. She has been a steering committee member since the beginning, so is very, very involved with the roundtable and knows all of the historical context. And we are so excited that she has agreed to represent the roundtable with Jaime next year as a co-chair. So please join me in a virtual round of applause. You will hear from her later on in the summit. She is going to be participating in a panel. So congratulations, Yvonne. We are so excited. So just very briefly, our steering committee members who are serving a 2-year term, they will be with us until 2025. You can find all of this information on our website, as well as pictures and bios. So anyway, thank you to all of my steering committee members for all of your time and insight as well. So with that, I'm going to pass it over to Modele to announce our inaugural Hypertension Hero Awardees.
Hello, everyone. This is, I'm so excited to recognize the inaugural recipients of the National Hypertension Control Hero Awards. The thinking behind these awards, we have a lot of members of the roundtable who are doing phenomenal work. And we thought that it'll be befitting to recognize a few people who have been doing equitable work towards achieving hypertension control. In thinking about the criteria for selection, we made sure that we looked at organizations in reviewing the applications who were working towards addressing equity in hypertension control, who prioritize cross-cultural collaboration, and they worked together as a group to make sure hypertension control was a priority. As recipients of this award, they'll be honored on a website and featured on an upcoming newsletter. So not in any order, but recognizing the 3 recipients. We had a lot of applications, but we picked 3 inaugural recipients. And the first recipients we want to recognize is the California Right Meds Collaborative. The California Right Meds Collaborative is a partnership between health plans, community pharmacies, and federal qualified healthcare centers. They provide comprehensive medication management to vulnerable, underserved patients with persistently poor control of chronic diseases, including hypertension. CMM is a pharmacist-led service, and I know that, as you heard today, the role of the pharmacist. In fact, there's data to show that pharmacists do a better job than doctors in controlling blood pressure. So CMM is a pharmacist-led service that involves interviewing patients, identifying all barriers to poor control of chronic disease, including hypertension. They provide education about this disease states and the role of medication therapy. They not only do that, but they formulate a treatment plan that addresses medication therapy as well as resources to support social needs. And on behalf of the California Right Meds Collaborative, we're honored that Dr. Steve Chen, who's also a member of our steering committee, is here to receive the award. Congratulations, California Right Meds Collaborative. Let's give them a warm applause. And then we move on to a second recipient, Midvale Community Building Community. They're a community-based, independent, nonprofit health clinic for the underserved people in Midvale in the state of Utah. This charitable clinic serves people without health insurance who have income below 200% of the federal poverty level. Recognizing the importance of hypertension control in this vulnerable population, they applied for funding through the Millions Heart Health Equity Initiative to provide no-cost self-measured blood pressure cuffs to patients with previously undiagnosed or uncontrolled hypertension. And this funding enabled them to purchase subscription to Dispensary of Hope, which in turn allows patients to fill no-cost prescriptions for antihypertensives at the point of care. In their nomination letter, they noted that under the leadership of Executive Director Mariko Agramot, they should be recognized as a hypertension hero because they identified a need for hypertension control and education in this priority population. And they used every resource at their disposal to meet the need through innovation. They really embody the mission of the Roundtable through partnerships, through innovation, through everything they do to achieve hypertension control. So we want to recognize Dr. Mauricio Agramot, and we thank you for what you're doing and to congratulate you for being an inaugural recipient of a Hypertension Hero Award. Let's give him a warm applause and congratulations to the Midvale Community Building Community. Congratulations, sir. Thank you. Last but not the least, we want to recognize the Minneapolis Heart Institute Foundation. Their mission is to improve the cardiovascular health of individuals and communities through innovative research and education. The research encompasses both clinical and population health efforts aimed at improving modifiable cardiovascular disease risk factors. And they find innovative solutions for those with cardiovascular disease. They have an award-winning New Ulm project that was funded for 10 years, and they were able to improve blood pressure control of an entire community using a comprehensive approach that provided interventions at the individual level through policies, and that impacted both the nutrition and healthcare environments. They have a multitude of hypertension-focused programs, and they have, through community engagement, connected with faith-based organizations. They've provided innovative patient care, and they've sought to provide inspiration to youth. And they've also amplified the voices of those who needed it the most. So let's give a warm applause to Minneapolis Heart Institute Foundation. And we acknowledge Ms. Gretchen Branson on behalf of the Minneapolis Heart Institute Foundation for your wonderful work, and congratulations. And we just want to say congratulations to everybody. We recognize that everyone is doing a great work, but we're so proud to honor these 3 inaugural recipients. Thank you for all you do.
Thank you, Modele. And a reminder, as Modele mentioned, we will be recognizing them in our newsletter as well as putting them on our website. So congratulations to all of the 3 winners. We so appreciate everything you do in the communities that you serve. So with that, part of the roundtable is really being the glue that brings everything together. And we wanted to next give a report on the Federal Council of Hypertension, because we do work with them and align some of our initiative and focus with the work that they're doing. So with that, I would like to invite Dr. Dorothy Fink, the Deputy Assistant Secretary for Women's Health at the Director on Office of Women's Health. So Dr. Fink, the floor is yours.
Good afternoon, everyone. Thank you for this opportunity. It's been wonderful to hear the discussion so far, and we're looking forward to sharing more about the work that we've been leading through the Federal Hypertension Control Leadership Council. And so I know you all have heard updates from this in the past, but we wanted to reshare our guiding vision, which is to really control hypertension for all Americans, focusing on the fact that we can truly save lives, improve health and resilience, as well as reduce costs through doing this. On the next slide, you can see all of the federal agencies involved, which is really an incredible way for people to come together in a focused way around hypertension. And so over the past several years, we've had all of the people with stakes across the federal government really thinking about how we can be inclusive of hypertension in so many of the actions that we take. And so in terms of the action framework and initial priorities, really it's a 3-pronged approach in terms of improving detection, improving control, and improving prevention. And you can see highlighted in red are the areas that the council has been focusing on first in the past years, but really all of these areas are an emphasis for us. And so thinking about how do we find undiagnosed patients hiding in plain sight using electronic health record diagnostic algorithm. On is through the improving control pronged approach is advancing the uptake and practice of SMBP, which you'll hear a little bit more about some of the work that we're doing on that, both through this council and through our Office on Women's Health in a bit. And then improving prevention. And so really thinking about increasing access to safe places to be active and having participation in lifestyle programs and implementation of physical activity guidelines. You can see all of the other areas here as well, but I wanted to point out the ones that we've been most focused on so far. And really each action was drafted based on its impact, feasibility of implementation, opportune timing, and the ability for different agencies to take ownership of. And so each action is examined for its impact on health equity. And so in terms of wins so far, we really are excited to share that we have department-wide actions to advance SMBP and physical activity. Another aspect of this is inclusion of both physical activity and average blood pressure measurements in the United States core data for interoperability version 4, which will be and essentially means that in future versions of the EHR, we'll have better access to this information. As well as internal leadership briefings on impact of action and actions to improve hypertension detection and control. Include maternal hypertension, SMBP communications toolkits, as well as an action plan to improve detection and really find those hiding in plain sight. And so that wraps up the summary from the council. And I am also happy to turn things over to Kiva Nelson, who is a public health analyst and team lead in our division of policy and performance management, who leads you.
All right, thank you so much, Dr. Fink. Hopefully, let's see if we can get this. All right, great. Hopefully everyone can hear me okay.
You're great.
Okay, thank you. As Dr. Fink mentioned, my name is Kiva Nelson. I'm a lead public health advisor within the Office on Women's Health, and I do lead our performance management efforts within the office. Just to give you a little bit of background about the Office on Women's Health, OWH, as we affectionately call it, provides national leadership and coordination to improve the health of women and girls through policy, education, as well as innovative programs. The vision of OWH is for all women and girls to achieve the best possible health. So one of the efforts that we have stood up is our self-measured blood pressure program. And the SMBP program continuously works, and this is through the fostering of both public and private partnerships to build a network of 47 organizations that come together and support, as well as drive outreach and education, as well as share information and better meet the needs of individuals living with hypertension and encourage them to take control of their health and blood pressure by implementing self-measured blood pressure programs. It is extremely important, and we always emphasize this to our network, of the importance of women and girls, especially those with underlying health conditions such as hypertension, diabetes, obesity, cardiovascular, as well as respiratory conditions, and older adults to take care of their health. More information can be found out about the Office on Women's Health if you check out our website on www.womenshealth.gov. What you see here is a screenshot of some of our resources that have been stood up on our dedicated webpage for this SMBP program, and resources, as I mentioned, that can be found here that are useful and helpful and have been grouped, such as heart disease in women, healthy living by age, as well as healthy eating, just to name a few. We also have shared resources from some of our SMBP champions and experts within the field, some of which are on today's call. So I would encourage you to definitely check this out, learn more about us as well as our SMBP program. You have the links available here so that you can share more information about this great program. So next up, I would like to speak with you all about considering becoming a women's health champion. The Office on Women's Health leads a wide range of activities and programs, including some very key observances, such as National Women's Health Week, National Eating Disorders Awareness Week, National HIV and AIDS Awareness Day, as well as the National Women's Blood Pressure Awareness Week, just to name a few. We work and have set this opportunity up for organizations to become a women's health champion, and it would be a great opportunity for you to consider joining us in these efforts during our upcoming National Women's Blood Pressure Awareness Week, which is coming October 15th through the 21st of this year. Women's health champions may receive recognition from the Office on Women's Health on our websites, such as womenshealth.gov, girlshealth.gov, and or our social media platforms. And you may also, if becoming a women's health champion, may receive toolkits and other information for further dissemination. And as I've mentioned earlier, additional information can be found at the following Federal Register notice located at the bottom of this slide. So wrapping things up, I wanted to share with you just a little bit about our upcoming National Women's Blood Pressure Awareness Week. We are so excited about this. Our theme for this year's observance is getting to the heart of it all. And this week emphasizes the importance of blood pressure control and heart health on multiple socio-ecological levels. It looks to empower women to take control of their health through realistic and attainable behavioral changes. But it also highlights community, state, as well as national initiatives that support women's heart health. This observance will also look to highlight disparities in heart disease that exist for both underserved populations, as well as hypertension considerations for both pregnant and postpartum women, as well as the impact of mental health on hypertension. And we also look and are really excited to feature rapid response techniques to provide life-saving care during this upcoming observance. So I would encourage you all to join us for this upcoming observance. And my last slide, as you see here, thanks you for your time. And if you have any interest or would like to participate in our upcoming observance or have any questions about becoming a women's health champion, please feel free to reach out to myself. My email is attached here, and we look forward to working with you all moving forward.
Thanks, Kiva. And one quick question I have for you. Will you be, so first of all, the Roundtable is a member of the your SMBP partner program. So we're so incredibly honored that we were accepted to be a member. Also, will you be able to provide any social media copy for that week that we can push out on our social media platforms?
Yes, we are finalizing the finishing touches on our social media toolkits that will be coming out and made available to any and all to share for our upcoming observance. So I will happily send that out to you, Jenny, and then you can share it further with the group.
That's fantastic. We're happy to blast that out to all of our members. So thank you for that.
Great.
Thank you, Kiva. Thank you, Dr. Fink. And also Kiva is one of our steering committee members as well. So thank you for your time throughout the year and your support and insight. So with that, we're going to take a 9-minute break. I will play music, so feel free to turn off video, step away from your desk. We'll come back at 50 after the. Welcome back, everyone. I hope everybody was able to stretch your legs and maybe get a few dance moves in during the break, but I'm so happy everybody's back. We're going to jump right into it because we're just a few minutes behind schedule. But our next session, I know Dr. Adams talked about this, Q talked about this, and we really want to focus on making the business case on hypertension control. So with that, I'm going to invite my colleague who I work very closely with, Diane Kolak from the CDC Foundation, to start off this session.
Great. Okay, now we're ready to go. Hi, everyone. My name is Diane Kolak. I'm a program officer at the CDC Foundation, and it's my privilege to work on the National Hypertension Control Roundtable with many of the esteemed speakers who you've heard today. In keeping with disclosure that others made today, I'll tell you I also have controlled hypertension, and I use a self-monitoring blood pressure monitor regularly. Today, for this presentation, I am joined by two colleagues. Michelle Bildner is a project manager from the CDC Foundation, and Meg Guerin-Calvert is Senior Managing Director at FTI Consulting, and she is the president of their Center for Healthcare Economics and Policy. I'm going to give you a little bit of background on the CDC Foundation in case you've never heard of us or aren't familiar with us. How we work, why this project is important, and why this project is important now. The CDC Foundation is the go-to nonprofit authorized by Congress to mobilize philanthropic partners and private sector resources to support the CDC's critical health protection mission. The foundation helps the CDC to save and improve more lives by unleashing the power of collaboration to protect health, safety, and security of America and the world. And we believe people, groups, and organizations can have a greater positive impact and can accomplish more together. And you've heard that through all of our presentations and speakers already today. Our work at the CDC Foundation generally falls into the categories listed here, and this project falls into that first category, safeguarding Americans' health. Okay. I'm going to skip some of these slides because I want to go a little bit quicker. You saw a slide, who is affected by hypertension? I know we have a really knowledgeable audience here. One thing that we found through this business case for hypertension work, and a statistic that I wanted to highlight is that high blood pressure, as we know, is the most common health condition among US adults aged 18 to 59, but also is more common than depression and diabetes. And as we start talking about what employers can do and what the business community can do, there's not a lot of awareness of this. So we felt like this is a really important fact that we wanted to highlight in today's presentation. And with that, I'm going to turn it over to my co-presenter, Meg.
Great, thanks very much, and have enjoyed listening throughout the prior sessions. But I think as Diane has highlighted, and as we were focusing on here in terms of a business perspective, it's a workforce issue that affects individuals, their employers, and factors critical to a business success, particularly risk factors, some of which are unknown. But what we want to highlight here as a starting point, and this is based on two major surveys, one most recently in 2022, the previous one, actually the most recent one in 2023, and then in 2022, is a real change, which it is now the fact that a question has been asked, why should CEOs, C-suites, boards care? It's because survey evidence is showing increasingly that a number one priority for CEOs is really the physical health and well-being of their employees is number one, as well as their community workforce. And as we'll get to later on, that action of engagement with employees and with communities and action on hypertension is something that enhances engagement and retention for CEOs, so makes it a self-fulfilling or a self-return kind of priority, not just a survey saying you should think about this, you should do this.
So we're running with that prioritization, right, for this work, and specifically been making the business case with FTI for employers or purchasers, one of the 7 Ps that we heard about earlier. And I think what we also really want to highlight is that employees with hypertension are largely unaware of their diagnosis. Of those who are not even aware, over a third do not have hypertension under control. So we're seeing really big opportunities right here in this awareness piece, and then moving into the control piece. And why that matters for employers on the next slide. We know that hypertension, like other chronic diseases, can occur with other conditions, but we know also of this half of adults that do have hypertension, they do tend to also have at least one other health condition, which is really important for us to highlight for employers, especially as they're looking at their data from their vendors and their pharmacy and their health benefits. And then a little bit more scary and more daunting, and making this work even more urgent, is that nearly 40% with hypertension have 3 or more conditions. And what this leads to at the employer level is that employers do face and have to absorb those higher healthcare costs from employees with hypertension than those without. And we're seeing that 44% higher cost among employers. And then by 2027, there could be an increase in $25 billion in additional cost based on the current trends of hypertension, unawareness, and lack of control. Another impact for employers is at the productivity cost, as well as the annual cost of time away from work, right? And so those tend to go together. And there's a hidden cost here. And Mega, I want to let you share a little bit about this hidden cost aspect.
Very much so, because if we go to the direct costs, which Michelle referred to a slide or so back, these are ones that oftentimes are available at a national level or a broader level, but for a given employer, even a larger one, may not be as known to it as to what the business risks are, or what the magnitude of the costs are, because they may not understand some of the basic data pertinent to them as to how many of their employees have hypertension, how many have it controlled, and where and how does it factor into what their actual costs are in terms of utilization of various types. So this is one that, may be a little bit closer on the radar screen, but I think if we go to the next slide, this is the part that tends to be the indirect costs are much more hidden and are the much more significant business risks, because in most circumstances, if someone is losing a day due to hypertension, which does happen, as Michelle showed us, and as the evidence demonstrates, it shows up where there may not be a substitute for the employee, so it's lost productivity for those days that occur across the year. And you can see here that it's highly relevant as to what those costs are for individual large employers who have estimated it. And that is particularly a business risk for the business itself, as well as the community, in terms of the health and the welfare, the well-being of the labor force for a particular employer and its revenues. So this is one that really does pose a significant and perhaps unquantified business risk.
So we did our due diligence in the beginning of this work to really unpack the data for employers, and it, separate from what is at the population level. Where can we zone in for employers? And we did come up with a couple of different solutions thanks to FTI's leadership and collaboration. And so we really have been focused on the purchasers and one of those 7 Ps. And created a budget impact model. And so when we launched the tools to our business partners and participants, we hosted a couple of different webinars to launch this work. On the next slide, this is a result from one of the live polls that we hosted during one of those webinars. And I think it's clear that a budget impact model is new to at least over 50% of these participants. So using a tool like this is new. So maybe this is filling a great gap so employers can start to measure and monitor performance. And then on the next slide, not only had folks not heard of it, then of course, not many have used a budget impact model. So our work to fill this gap is really centered on utilization, launching and utilization of this budget impact tool, and another one that I'll let Meg get to in a moment. But Meg, you want to share a little bit more about the budget impact model and how it works?
Okay. And I think if we can go to the next slide. So a budget impact model is really a way of taking limited actionable data, which is what employers want. They want in all of their business decisions. And as Michelle mentioned, some basic metrics and measures that are pertinent to them. So what it does is it asks for and it uses basic data and information that an employer or its benefits manager or other senior executives will likely have ready to hand or can get. And it puts it in a model that allows them not only to estimate what's the impact on my population of measures that I need to know to understand what's my risk, where is it, what amount of the workforce is impacted, and then what is the impact of that in terms of basic financial measures, in terms of costs, but also some projections. If I stand still, what is it? So let's go here through what it is. It also, I would say, personalizes it. One of the issues that we discovered is that while national data are known, the actionable data to really understand for a given employer, small, medium, and large, what is my story? So first of all that's really needed to run the budget impact model that we created is what's your number of employees. What's useful to have, but the data in the model can be put in for you. And again, these are not too surprising. It's what's the employee population demographics? Is it mostly a younger workforce? Is it an older workforce? What kind of industry sectors are you in? Many businesses, many employers, and those that we surveyed and worked with had a retail arm, had a manufacturing arm, had a distribution arm, or were a localized large plant, or were a transportation company. A lot of differences. And that matters because the percent of employees with hypertension could vary depending on age, demographics, other characteristics. Wanting to know the average median wage, the average total healthcare costs, are again to put it in context and a perspective. And then the average productivity loss is something some employers will have, others won't. And so the model is populated. So these are the elements that are used. And then we have set it up in such a way that additional data can be brought in. So with these actionable data, what does the budget impact model get you? If you go to the next slide, is what the model results are. It's looking at what's the additional cost of hypertension? What's the additional cost of uncontrolled hypertension? Those are the things that matter to an employer to understand those risks and also how significant it is. And it says what's the extra financial impact. So it can be translated into dollars as well as people. So the model results give you what most employers want. What's the scope of my issue? What's the estimated number of employees that I cover with my plan that have hypertension? And then some breakdown by types of demographics. What's that additional cost due to hypertension that Michelle talked about? And then what's the additional, what we call total employer cost? That's the productivity cost as well. It's presented and done in such a form that it's actionable, it's presentable, it can be shared with internal teams, senior leadership, but also to then say, well, let's think about this as to our priorities and designing interventions. So those are the elements of the outputs of the hypertension model. If you go to the next, this gives you an idea of how can the data be presented. This is the beta version, which we've tested with multiple employers already, are testing further, but it's to give what many CEOs, CFOs in particular, are looking at. I have a CFO that are looking at, well, what's the overall impact? And the idea is to have a single high-level dashboard. This happens to be with the overall US population, but for a given employer, if they have 500 or if they have 5,000 or 15,000 employees, it's going to tell them their total number of employees, the total number with hypertension, those two particular metrics of the medical costs and the annual costs. But what we've provided as well in this model is some breakdowns that we believe that are actionable and that give insights in terms of what's the demographic breakdown. So to provide those insights, and this can be done at multiple levels, that breakdown of what's the nature of the medical costs, how much is coming from utilization of healthcare services, pharmacy, and so on. And then a 5-year projection, the idea of here's your estimate right now. If you stand still with normal changes that are predicted for national and other populations, what will it look like next year, the year after? And similarly, what are the cost impacts, those additional cost impacts this year versus other, to again, to try to give information that will motivate action and also allow tracking. So these are the nature of both the healthcare costs, those direct costs, as well as indirect costs. I will mention that behind the scenes, what goes on here is the ability for an employer to have up to 5 different workforces that they're looking at, because those that are on the front lines may have higher rates of hypertension, may have higher rates of uncontrolled hypertension. So to really let an employer look at and evaluate, personalized to themselves, what's the impact, what's the cost, so that they can think about where should we prioritize, where should we intervene in order to reduce those risks, but more importantly, to improve the lives, the well-being of our workforce and our community.
Meg, I love the emphasis on the really tailored opportunity with the budget impact model, and that we've created something that is turnkey. And we hear both of that from employers, right? We know that workforces aren't all homogeneous. There's a lot of heterogeneity. The more we think about different industries, different workers within the same organization. And so this tool has capacity to do that. I think another opportunity that we explored and filled the gap on, if you will, is in this claims analysis guide. And so we didn't just stop at the budget impact model, but also developed a claims analysis guide. And you can see on the next slide, one of our live polls is that, we also need to start with where employers are at. And not all employers do have good access to their data from their vendors. We hear our business coalition and groups on health partners advocating, trying to mobilize and encourage employers to ask for that in their contracts. How are we going to get the data back? Can it be tailored? Can it be customized? But we see here in this result, 50% of folks don't even know or don't have access. But then even a bit more troubling perhaps is 20% of folks get what they get. The tailorability, the report out, isn't as useful as it could be for employers to really mine their own data. So we went ahead and asked FTI to collaborate on making a claims analysis guide tool. So another opportunities for employers to look at tailored information for their workforce, ready to go as a tool itself, turnkey. So Meg, I'll give you a moment to talk a little bit more about this claims analysis guide and the 3 key questions that we're really hoping to help employers answer by using this as a tool.
Great. Thanks, Michelle. And this really goes back to that idea of having tools that provide actionable data. This is a treatable condition, is what we heard consistently, including from our major employer panel, that it is treatable, it can be actionable. And so this claims analysis guide is diagnostic, but it's particularly aimed to be thinking about, well, let's start tailoring some interventions. And as you were saying, performance and measurement, Michelle. So the first and most important is that starting point for the particular population that's covered, historical and current data on how many employees have hypertension. So that gives you an immediate grounding of how many have been diagnosed. It can be updated, and that's a fundamental set of information. The next is drilling down further into what the budget impact model gave the insights about is, well, really, what are the medical costs? What is the utilization on those direct medical costs in terms of, the demographics, the characteristics, but also by type of care? Those are very important in terms of understanding those elements. And also that it now allows bringing in other data, such as the social deprivation index and other measures. So there's some real drilling down that we heard in our employer panel was very important. They really wanted to be looking out in the community and across their employees to deal with health disparities, health equity issues. The third question goes back to that point Michelle made that we understood and heard from so many, which was, well, if controlling matters, how are we doing for those of my employees who are treated for, what is adherence? So it's not invasive. It's something that really is getting an aggregate measure to get a handle on, is the education occurring? Is the treatment occurring? Is that an area where there could be more done to encourage education and awareness? So that's an output effect. All of this can start as a baseline, a diagnostic, but it also can be working with those vendors and others. And what we had found is that this framing is something that could be handed off to a payer, an insurer, could be handed off to a benefits consultant and said, I'd really like this data. It can be aggregated for me, but I'd really like to see the answers to this for my population.
And thanks, Meg, and thanks, Michelle. One of the things that I wanted to emphasize is this work directly came out of last year's summit. So I know a lot of you who are here in the virtual room with us today were here last year. One of the things that we asked during our Zoom poll last year is, what do you need? What would help move the needle? What would make your jobs easier? And there was a lot of people said that they needed the tools to be able to make an economic case, a business case for treating hypertension. The other thing that I wanted to underscore is that these tools that FTI has built, it's not software you have to pay for. They built it in an Excel model. So it's very accessible. It's very, once you understand how it works, very easy to use. We have user guides that go along with these that walk you through step by step. Claims analysis guide is just a PDF with lots of definitions. We really try to make things simple. And as Meg said, and Michelle said, we have been doing this beta testing with employers. We're still in that phase. And so some of our roundtable members have been so gracious with their time to go through and use the budget impact model and use the claims analysis guide and provide feedback. If anyone's here and wants to do that, we would love to share these tools with you, and we would welcome any feedback that you have. Great. And I think with that, I'm going to turn it over to Michelle.
Yeah, definitely. I think along, the lines of steps you can take while sharing this work with a business audience that you have, but I think our main message for employers is that they really can take action. Two main mechanisms: innovative insurance design and/or specialized benefit programs. And we have heard really good examples of this being deployed in different sectors and employer bases. And so, Meg, I don't know if you want to share a little bit about a story from David or Jake, just how they've made an impact in hypertension prevention and control in their own communities by thinking in these innovative ways.
Great. Thanks, Michelle. And what Michelle is referring to is Jake Flights, who is the director of benefits and well-being at Paychex, has about 15,000 employees. David that she's referring to is David Hines, the executive director of employee benefits for the Metro Nashville Public Schools. They've got about 11,000 faculty and other members and staff that they are involved with in a very large metro school district. While these are large, the examples that they shared with us of what they've done are replicable across sizes of businesses. And a couple of the interventions that they did is to go to value-based directly, is to remove obstacles to costs and co-pays, is the major change and the benefits that they did. But interestingly, what Jake shared with us was actually using hypertension control and hypertension diagnosis as the lead-in because it was treatable, even though they had a younger population on average. They thought it was the best way to get into a conversation with employees around managing chronic conditions and health, but also recognizing that it had something that could be dealt with immediately with access to monitors, with lifestyle, and with medication adherence, but also to talk about how an employer could engage with its employees and its workforce to say, we care about you. Going back to that initial message that we talked about at the beginning, and that was the important part. From the Nashville schools, it was the idea of looking beyond healthcare cost, again, to that overall health and productivity well-being. What they did is eliminate all the cost barriers, but also provided monitors or other self-monitoring devices that could be used by any employee who was diagnosed with hypertension, and also to provide education and so on. So that gets to that specialized benefit programs. They also put the blood pressure assessments and so on out in the community. That was another initiative that Paychex worked with virtually every provider, business, and physicians in Rochester to put in a community-wide program with the goal of reducing uncontrolled hypertension significantly over a period of time. So I think those are some of the things, but maybe just to close with, one of the things, Michelle, you talked about measurement and performance. And they shared some new measures They showed, first of all, that it did not take much of a percentage change in healthcare or other costs to make a difference to get action. The second thing is that they thought the single biggest thing was showing that to their C-suite or their boards that they were taking care of their employees, they were improving retention and engagement as important returns that were obviously monetary, but also non-monetary. And interestingly, we're trying to track back the idea that that had even better, not just productivity, but reputational issues, that they were great employers to work for. And so that was, some metrics that they were starting to track. But lastly, they were drawing a connection between, did the programs actually result in improved health? And did it also have an impact on addressing health disparities in certain populations? So those were, some great things they shared with us.
Thanks, Meg, for reminding us of the deep work that it takes to make these kind of changes, even with a large workforce, such as both Paychex and Nashville Public Schools. But we know employers do have the power. So how do we help them make that case? And I do think these tools are a path to that. And I know we have questions in the chat, and I'll let Diane help us moderate any new questions that come in.
I have a question for you all, and then I think due to the interest of time, maybe we can respond to some of those questions via chat box so we can all see. Thank you so much. So thank you both, all three of you. One question I have for you, and you don't have to answer this right now, but how can the payer task force support this effort? I know you all came and spoke to our payer task force, and that one claims analysis toolkit that you all created is so powerful for an employer to have in their hands. But on the other end, what can our payers do to maybe utilize that tool as well, or encourage their self-insured groups to use that tool? Does that make sense?
It makes great sense. And maybe to start, I think the partnership between payers and self-funded employers is a vital one, because I think that, as you heard, in order to be able to engage in action, there has to be a way that a motivated employer can implement interventions and track them, but also have them occur. So I would say two things. One is it would be worthwhile perhaps to sit down with major employers and look at the results of the budget impact model, or for payers to run the budget impact model and look to see for some of their major employers what it would look like, because you can estimate the data yourself. But I think also to take the claims analysis guide and think about how to operationalize it even more. What I've seen some payers do is do more of a scorecard dashboard results to be able to show here, if you're doing these particular kinds of interventions and focus, getting these kinds of tools, how can it work? Or to help an employer, change the nature of their benefit design to focus on where are my barriers? Where am I not getting people into care, encouraging them to get into care as well as I could? Where are the gaps? Where are the big access issues? So I think that would be partnering and looking at those kinds of elements. Those are some immediate ideas.
Thank you, Meg. Despite what Dr. Emanuel said at the beginning of the summit, I have a lot of faith in our employers. And as Jaime mentioned on the payer task force, there's a lot of great people also working within payers that really want to try to figure this out. And you heard from some of them today. So I love the idea of partnering and figuring out how we can facilitate that from a roundtable perspective. So thank you all so much. This was fantastic. More to come, I believe, Diane and Michelle, from you all. And if you could just answer some of the questions in the chat box, that'd be helpful. But as we move to the last but not least session, again, I hope you see the theme here is that everything we do at the roundtable is incredibly action-oriented. all the research that is out there, we kind of take that in and work with our partners who are really doing some amazing work on the ground. And our job is just to facilitate and scale it and have these really hard conversations with our partners, with partners we would like to engage, or organizations we like to engage in. So we are ready to get going over the next year. We'll, as I mentioned, we'll be launching some new task force. So with that, I also want to bring up and invite Dr. Eduardo Sanchez to lead our panel on a multidisciplinary approach to improving hypertension control. I'm sure he doesn't need any introduction. I'm sure we all know him, but he is the Chief Medical Officer at the AHA, and also our original co-chair of the roundtable. So Dr. Sanchez, I know you are in another conference right now, so I'm so appreciative that you're able to step out and lead our next panel. So I will pass it over to you.
Thank you, Jenny, for that kind introduction. I'm at another hypertension conference, by the way, so I couldn't get enough today and decided to do two. I will say that I'm better than the CMO. I'm the CMO for prevention. And so my focus is on keeping bad things from happening. And I really, really appreciate this past panel. The 7 Ps, I've got an 8 on because the American Heart Association went from Life Simple 7 to 8, Life's Essential 8. And I'm thinking I'm adding a new P to y'all's 7, and that would be partners. Because all of the difference-making health initiatives that I could think of, to all the way to remote history, were multi-sector, multi-pronged, and multidisciplinary. And so I am pleased to be moderating this panel where the conversation is going to be about the multidisciplinary approaches to improving hypertension control. 3 great persons who are doing tremendous work. I'm going to be brief on the introductions. Just in the interest of time, their information is available in other places. The 3 panelists are Miriam Patanian, who is a senior public health consultant at the National Association of Chronic Disease Directors, leading health system initiatives addressing hypertension, million hearts, and cardiovascular health. Also, Dr. Yvonne Commodore Mensah, friend, first of all, a nurse scientist and CVD, that is cardiovascular disease epidemiologist, who's an associate professor at the Johns Hopkins School of Nursing, Johns Hopkins Bloomberg School of Public Health, and the Johns Hopkins Center for Health Equity. And Meg Metter, who was referenced earlier today, serves at the National Association of Community Health Centers, that would be NAC, as Director of Clinical Integration and Education, where she designs, implements, and evaluates integrated strategies, quality improvement initiatives with the community health centers. So welcome, panelists. And we're going to do this like a game show. You get to sort of hit the buzzer, and whoever goes first gets to answer the question. Okay, I'm just kidding. I try to mix it up with a little bit of humor every now and then. So I'm going to go around in sort of a round table. I'm going to ask you to be succinct. So you need to cover a lot of material, but don't use more words than you need to. That's the challenge. And each of you is doing interesting work, and I'm going to just ask you to tell us a little bit about that work that you are doing. So I'm going to start with you, Meg. Tell us what you've learned or what you want to share about 2 projects you're leading, improving, among others, improving blood pressure control with African Americans and hypertension medication in trusted spaces.
Thanks, Eduardo. So I will do my best to be succinct, but I do want to give just a little background on what these projects are. So NAC is currently engaged in 2 projects specifically focused on improving hypertension outcomes among Black and African American people. Both are in the evidence translation or implementation science space. The first is a multi-year project that involves 7 health center controlled networks and 20 of their health centers across the country. It's centered on the strategies outlined in the 2019 article by Bellows and colleagues. I think many of you are familiar with that. Focusing on those most impactful clinic-based strategies that will allow us to achieve 80% hypertension control nationally. So that's treatment intensification, shorter follow-up intervals, medication adherence, and then we're also encouraging SMBP to support these strategies. That's the first project in 2 sentences. Our second project, Hypertension Medication Management in Trusted Spaces, is a pilot project to try to learn whether and how we can implement Ron Victor's LA blood pressure barbershop model into practice in a sustainable way using community health centers as the primary care provider. So this is a pharmacist-based model, multidisciplinary, that engages people in their communities in a trusted space. So to answer your question, we've learned a lot from these projects. I'm glad to unpack any of this, but I would say the top 3 things that we've learned that work best are standardized treatment protocols that codify acting rapidly to intensify treatment using fixed dose combinations. So that's a lot, a mouthful, but that's the number 1. The number 2 is something that Karen Margolis actually mentioned, which is proactively meeting people where they are. And really the number 3 supports that second one, which is using SMBP to support diagnosis and management. So I have a lot of things to say about that. I'm just going to pick one really quickly, which is the proactively meeting people where they are, because I don't think it's really been talked about a lot today. I think we need to shift the way we think about hypertension. It means not centering hypertension management around in-person encounters, but proactively engaging and empowering people using technology like telehealth, self-measured blood pressure monitoring, bidirectional text messaging, and targeted outreach. I think we need to shift the whole care model to this proactively engaging people where they are. And then I'm going to stop and give others a chance to speak, but I would love to also share later what's not working and what I think we should do about it.
That's a great teaser, because I think that there's tremendous value in sharing what doesn't work and or what was really, really, really hard in getting the work done. So hopefully there'll be time to come back to that, or I'm thinking fireside chat. So Yvonne, let me ask you, share some things that you've learned from, I'm going to focus on 2 projects that you're involved with. One is Linked BP, the Linked BP program on the one hand, and then the Linked Heart program on the other hand. So you're going to need to tell us what Linked BP is, and then what Linked Hearts is, and what you've learned.
Great. Thank you so much for the opportunity to participate on this panel. So first, I'll start with Linked BP. Linked BP stands for Home Blood Pressure Telemonitoring linked with community health workers to prevent hypertension. It's a mouthful, and that's why we call it Linked BP. So I think we can all acknowledge that the burden of hypertension is remarkably high. So we need to focus on preventing hypertension in the first place. So this project is funded by the American Heart Association as part of the Health Equity Research Network on the prevention of hypertension. So the idea here is that when you look at patients who have elevated blood pressure or untreated stage 1 hypertension, how do you link them with community health workers to receive the support they need to make the necessary lifestyle changes, as well as address their social needs to prevent that progression from elevated blood pressure or untreated stage 1 hypertension to stage 2 hypertension. So we want to prevent stage 2 hypertension. And a key lesson we've learned in this trial, we just started recruitment about a month ago, is that when we do reach out to patients who are seen in community health centers and primary care clinics, one of the things we've heard is, I don't have hypertension. So conveying the importance of preventing that progression to stage 2 hypertension has been critical. We've been really fortunate to have engaged a remarkable community health workers. I'm a huge fan of community health workers and the amazing work that they do to meet our communities where they are. So that's been a lesson that we've learned, that we need to do the job of educating patients about what is elevated blood pressure, what is stage 1 hypertension, and how can we prevent hypertension from occurring in the first place? Because I feel like we don't talk about that enough. The second project is Linked Hearts. So another mouthful, it stands for cardiometabolic health interventions to control blood pressure. And that's funded by the NIMHD, the National Institute on Minority Health and Health Disparities. So the idea here is that we know that hypertension rarely occurs in isolation. So we are focused on controlling hypertension among adults who have hypertension plus diabetes or chronic kidney disease. And the model here is taking community health workers plus pharmacists. I'm also a strong believer in the amazing work that pharmacists do. So this combo of having a community health worker plus a pharmacist to address medication intensification, addressing adherence, and also addressing social needs. We are yet to start recruitment from that. So it'll be interesting to learn what lessons can be learned from this team-based care model and engaging different members of the healthcare team to achieve blood pressure control. So I'll post the links in the chat if others want to learn more. So I'll stop here.
Nicely done. I think you pointed to one thing that's really important for the National Hypertension Control Roundtable to get its arms around, and that's stage 1 hypertension. And how do we characterize that as maybe a yellow zone, kind of a cautionary zone? It's not red necessarily, definitely not green. And what are the things that one might want to be paying attention to? That's what I heard loud and clear from what you said, Yvonne. And now, Miriam, you're so special. You get to talk about 3 things. And so why don't you share with us a little bit about what you've learned from the Health Equity Implementation Project, the Million Hearts Hospital and Health Systems Recognition Program, and advancing pharmacy-related interventions to control hypertension.
Thank you, Eduardo. And it's been an incredible afternoon where I am to hear all of these amazing speakers. And I always enjoy getting to hear from Yvonne and Meg about the work that they're doing too. I'll say that I think the overarching theme that we've learned across these multiple projects is really about how critical it is to help coordinate and support the work among activated partners. So how can we help to really activate, to engage, to show the value for the multiple partners, that 8th P, Eduardo, that are required to help us really move that needle. We work really closely with the Million Hearts Initiative at CDC. So a couple of these projects, we receive funding from the Million Hearts team to help support. So the Health Equity Implementation Project is one where the focus is really to improve cardiovascular health by focusing on health equity and identifying a Million Hearts priority population. And so for those who aren't familiar, those priority populations include pregnant and postpartum moms with hypertension that we've heard about earlier today, those from racial and ethnic minority populations, those with behavioral health issues who use tobacco, people who have lower income, and those who are in rural areas or other access deserts. And so for this project, we wanted to see how people who can focus on any of those priority populations are then implementing Million Hearts evidence-based strategies to address their needs. We had, I think as a testament to just how much work is needed in this area, we were able to support 6 grantees. We had 106 applications. And so the need is really there for people to be able to do this work. And we found, really, I think the partners were showing us that they work with their pharmacy partners in their communities. They work with community health workers. They work with pharmacists, with nurses, et cetera. In fact, one of our inaugural hypertension heroes, Midvale Community Building Community, is one of the grantees of this project, and worked with community health workers to to identify a population, lower income people who have a history of hypertension, and to provide cuffs to these people. And then also, to have, an in-house pharmacy for patients so that they can receive their medication at the time of service. So this has been a really exciting project, and we're excited to share some of the great lessons that we've learned there. For the Million Hearts Hospitals and Health Systems Recognition Program, this has been a really fun program to build with the Million Hearts team over the last several years. And while we do obviously recognize hospitals and health systems, what I'll say is that many of the organizations that have been recognized, they're looking at their employees as a way to implement some of the Million Hearts strategies, right? So they're showing how they are working as purchasers, and how they're how they are valuing their employees by looking at improved nutrition and other sorts of strategies that Million Hearts has laid out. So that has been a really exciting program. I enjoy whenever we get to announce a new health system partner that's been recognized. And then for our pharmacy related work, we've had an opportunity through a couple of learning collaboratives to work with our state health department partners, and then pharmacy partners that they have each identified in their states. And through over the course of learning collaboratives, really having public health and pharmacy work together on these projects really helps to create that connection, see where each can help to support each other in improving hypertension control among their population. We've worked with a number of states through these collaboratives, and have been really excited to see some of the innovative ideas and successes that have come from them. One state has also been taking the model from the Los Angeles County barbershop program and implementing it here in Georgia. Another program is also has been working to implement collaborative drug therapy management programs. So these are all just really great examples of some of the work that we've been able to do.
So I started with multi-sector, multi-pronged, multidisciplinary. Y'all nailed that. Ergo, 8 Ps, not just 7. I'll just leave it there. So I'm going to do a little bit of a round robin to kind of round this up. That was really tremendous. It's the reminder that there's all kinds of really, really great work going on. And I suspect each of you can provide, some of you already have links for more information. And again, NHCR, this sounds to me like there's opportunity to expand this 30 minutes to something broader. But I'm going to ask each of you 2 questions. And again, y'all did a really nice job with succinct a minute ago. What's the biggest lesson that you've learned from the work? Not from each one, just one lesson overall. And then how can the roundtable help you achieve at least one of the goals that you have for the programs that you are working with? So biggest lesson, and how can NHCR support your work? And we'll do it in the same order. Meg, you're first.
I would say the biggest lesson overall over multiple years is that health centers are incredibly creative and resourceful and can lead the country in hypertension control if we help remove barriers to the most impactful evidence-based care. So that would be my overarching lesson. And let me talk about the roundtable. I have lots of thoughts, but I'll try to keep it succinct to this one, which is, I think there's a big disconnect between clinical guideline recommendations and the way clinicians continue to manage blood pressure in practice. And so we really need to think about how do we bridge that disconnect. I think one of the problems is clinicians were trained on start low and go slow. It's a mantra that they learn in med school, and it's right for many conditions, just not hypertension anymore. They still don't diagnose at 130/80. They still are, we have serious inertia around prescribing quickly, prescribing combination therapy. And so in our projects, we've made significant improvements, but not nearly what we could if we can crack the nut on getting clinicians to prescribe combination therapy and getting patients to understand that that's the norm, that most patients need to be on 2 or more meds, and that being on 2 or more meds is not a failure, but actually what's common, and it won't increase side effects, et cetera. So help us bridge that disconnect between the clinical guideline recommendations and the way clinicians continue to manage blood pressure in practice.
Yvonne.
Yeah, so following the theme of race to the top, I will say that in terms of controlling blood pressure, it's a relay race. And that's the lesson that I've learned, that we need all members of the healthcare team. And although the evidence in support of team-based care is quite robust, we still see a lot of opposition to engaging nurses, pharmacists, and I think Stephen provided an excellent example in the chat. So it would be helpful for the roundtable to consider how we could collectively address concerns from organizations that oppose legislation to advance team-based care in all settings. So it would be really helpful to gain the support of all members of the roundtable and those who are not at the table, to figure out how we can get consistent legislation passed across states that support the action. We've talked about the challenges, but if we want to do the work, we don't need another clinical trial. We know what works, and we need everyone to join this relay race, which is also a marathon. It's a long road ahead, and so we need everyone to come on board.
Miriam.
I think that I will, I'll go back to what I had said as my sort of overarching theme, as sort of the biggest lesson across my years in public health. I think, you know, what is critical is that we have all of the right, engaged, active partners at the table. And that is how we are going to move the needle. I think asking any one of the Ps to do this work, we're not going to get there. I think we have to have everybody at the table. And that's, I guess, also what I would say is, you know, the best way that the roundtable can support the work that we do. I think, you know, identifying where there are gaps, and I really applaud the standing up of the payer task force to really help to, you know, to understand some of the questions and have these great conversations. And then share, you know, share what they can out with not just the roundtable, but much more broadly. And I think, you know, as we expand the membership of the roundtable to include all those partners, I think, you know, just allowing the space for to hear what these groups need, so that we can either find it or help to create it.
Well, let me just say, this was an awesome way to end an awesome day. Congratulations to NHCR. Thank you for those who attended. As somebody who has been co-chair of the roundtable, it's really, really nice to see the progress that's been made. Judy Hannon put a comment in the chat. What a panel of great women. I'm actually going to revise that, because I'm adding 2 new Ps, and that would be powerful panel. My new favorite powerful woman is Dolores Huerta, who was one of the people who helped start the farm workers movement in California. She's the person who coined the term "Si se puede," and I think I'm hearing here, we can get this done. We just got to get all the stuff that's in our way out of the way. So Yvonne, Meg, Miriam, y'all were awesome. And Jenny Bogart, I'm handing it back over to you, the baton on this relay race.
And I am so happy to all be in the relay race with you, because I know that we will be able to make change. We've done so much in the last couple of years as a roundtable, and we're just getting started, as Jaime likes to say. So if you're not part of the roundtable, I invite you to join us. As I mentioned, we are incredibly action oriented. We will be hosting new fireside chats. I love Eduardo's idea of having you all come back. So we have a much deeper and longer conversation in one of our fireside chats. Another exciting thing I'd like to share is that our plenary speakers have agreed to join, be on a podcast with the CDC Foundation on the contagious conversation. I just got word of it. So if you would like to hear them continue the conversation that they started earlier today, more information will be shared with you all soon once that date is finalized. But they have agreed to join a podcast with the CDC Foundation. So we're really excited about that. I'm going to pass it over to Jaime and Modele to see if they have any last words, but I just want to thank everyone so much for the time that you all took to spend 3 hours with us virtually, as well as your incredible conversation in the chat box. We so appreciate it. We are recording all of this, so we will make sure to follow up with anybody if we didn't get to address it today. If you have any ideas for fireside chats or would like additional task force ideas or people to involve, please let me know. I'm always available and open to hearing any type of suggestions. So with that, Modele and Jaime, I will pass it over to you.
Thank you, Jenny. I don't know if you can see my screen, but I tried to create a word salad from all the input you had at the beginning of the conference. And the overall theme was hopeful. And I'm hopeful that together we can achieve equitable hypertension control. Of course, we identify from this word salad that there are challenges, there are barriers, but together we can do it. So thank you all for an amazing conference. I guess this is better. I will dare to say that this is better than the conference that Eduardo is. Is that now? Because we came up with practical solutions. And like Jenny said, we're action oriented. So I'm going to invite you all to join us in this race. And as a new co-chair said, it's a marathon. So we cannot give up until we achieve equitable hypertension control. So thank you all for joining us, and I will turn it over to Jaime.
Thank you, Modele. Well, I certainly want to stand between you and your hopefully lunch or your break, but I'll just say grateful as everyone else is. I'll personally say thank you to Jenny for organizing. Our executive director done an amazing job putting all of this together. Believe me, it's a lot of work behind the scenes that she does. And Valak has been, her partner also in this process. I can tell you what we have also achieved thanks to Janet Wright and the CDC and the CDC Foundation colleagues who have been also behind really supporting every single effort that we do, along with the executive and the steering committee. So very grateful. Also, we have to mention our original ones, John Clymer and Eduardo Sanchez, who really helped us get to where we are. My claim to fame is that my middle name is Eduardo, and that was the reason I became co-chair of this roundtable. Also very grateful to Modele because he has done an amazing job, as you all know, and we certainly still benefit from 3 more or 4 more months with her, and obviously past that as well. And clearly welcome and very much enthusiastically welcome Dr. Yvonne Commodore Mensajo. As you heard her, she's going to be an incredible, terrific co-chair. So I'm really looking forward to spending next year along her partnership and leadership. And to every one of you for being part of a mission-oriented work, because we are, as you heard many times, action-oriented. We're past the discussion why it's important to do it. It was like, let's just get to the floor and clean the floor and learn from doing it, and let's just get it done all together. I think we want to be the place where we convene all the stakeholders that are important. Everyone is important. And we know that each one of you is really contributing to what we want to achieve, which is, again, equitable blood pressure control. That's the low-hanging fruit. Let's take advantage of it. There's a lot of impact that we can have, so let's go for it. And I'll just finish saying, yes, we're just getting started. So more to come.
Thank you, everyone. I'll play some music.